Assalamu alaikum wa rahmatullahi wa barakatuhu. So we will discuss today in the previous class we have discussed till the investigations. So we will finish this topic of peripheral artery disease in today's class. Let's begin with the name of Almighty. So there are two classification to grade the severity of claudication. Okay, peripheral vascular disease, peripheral arterial disease in particular. One is Fontaine classification and one is Rutherford classification. Fontaine classification is classified as 1, 2A, 2B, 3 and 4. Rutherford classification from 0 to 6. So coming to Fontaine classification, 1 is asymptomatic, 2A is patient can walk with claudication to more than 200 meters before resting. 2B is patient will walk for less than 200 meters. 3 is rest pain and fourth one is ischemic necrosis, nothing but gangrene or ulceration. Rutherford classification, 0 is asymptomatic, 1 is mild claudication corresponding to the Fontaine classification of more than 20 meters. 2 is moderate claudication corresponding to the Fontaine classification of 2B, that is claudication less than 200 meters. Okay. 3 is considered as severe claudication, nothing in Fontaine. Fourth is rest pain. Stage 4 is rest pain of Fontaine classification 3. Stage 5 is stage 5 and 6 both are present in fourth stage of Fontaine classification. In Rutherford, 5 means minor tissue damage. What is minor tissue damage? It is non-healing ulceration, focal gangrene with diffuse pedal edema. Focal gangrene with diffuse pedal edema. What is major tissue damage? That is sixth stage. So extending above the transmetatarsal level, functional foot is no longer salvageable now at this stage. Okay, that is major tissue damage. That's about the two classifications of which are clubbed in this one table. This is from McMaster Expo of Medicine. Okay, just to know the severity. Now we will discuss the management. Okay, so management of chronic pulmonary artery disease we will discuss first. It can be uh, divided into four, as you can see here. The one is medical management and risk factor modification. Second is symptomatic pharmacotherapy for pain of claudication. Third is exercise therapy. Fourth one is revascularization. Okay, these are the four things we will discuss one by one. Medical management and risk factor modification. Okay, so you should main thing is you are modifying the risk factors. You are not seeing only the limb which is involved. You are seeing the whole picture of vascular system, and accordingly you are acting, so that the patient may not should not develop major events like stroke or MI. Okay, so number one is smoking cessation. This is very important. It stops disease progression and improves patency rates after interventions. And one thing we have learned, smoking cessation is the one important factor which is responsible for treatment failure in these patients. That's why smoking cessation is very important in these patients. Second is you should start antiplatelet therapy in these patients. So either you can use aspirin 75 to 150 mg daily or clopidogrel 75 mg daily. Why you are giving this? You are not giving only by seeing the limb. You are giving in order to reduce the risk of MI and stroke. So the presence of claudication, presence of peripheral artery disease itself is a clue that the cardiovascular risk is very much high in these patients. That's why you're starting antiplatelet therapy. So statin therapy also you will start. High dose, high intensity statins you will be given. You will be giving to the patient. High intensity, remember, not low dose, as we give in primary prevention of cardiovascular disease. So it is high intensity statins which you give. So either you can give atorvastatin, high intensity means 40 to 80 mg, rosuvastatin 20 to 40 mg. So target LDL reduction to more than 50% of the baseline or LDL less than 70 milligram per deciliter. One thing I forgot to say. So instead of using aspirin clopidogrel, you can also use Vorapaxar, or more commonly rivaroxaban 2.5 mg twice daily. This is a factor 10 inhibitor plus aspirin in low dose like 50 mg. Okay, 50 mg per day. Rivaroxaban plus aspirin also you can use. Antiplatelet with anticoagulant. This may reduce limb events, but this has a what do you call demerit, that is it increases the bleeding risk. Okay, so you see the context of the patient. Depending upon that, you decide whether to give this or whether to give this. So lipid control, I have said high dose statins you should give and target the LDL to more than 50% of the baseline or less than 70 milligram per deciliter. Blood pressure control is required, very important. ACE inhibitors are recommended for that because they improve the cardiovascular outcomes. The diabetes control, sugar control. So strict glycemic control. HbA1c, the target HbA1c should be less than 7%, which is generally recommended. And one important thing here is consider SGLT2 inhibitors or GLP-1 agonist because they have an increased cardiovascular benefit. Nowadays, this glimepiride and everything are have become second line now. The first line drugs are metformin, GLP-1 agonist, and SGLT2 inhibitors. So these two, no, they have a very good cardiovascular benefit. That's why these are the recommendations from many guidelines nowadays. Okay, so that's about modifying the risk factors. So first you modify the risk factors. Same risk factors which you, for example, a patient coming with coronary artery disease, which how do you manage the risk factors? In the same way manage here also. Second one is symptomatic pharmacotherapy. Suppose if the patient is not in critical limb ischemia, so that is one exception. If he is in critical limb ischemia, then you need to give, that the management differs. But if he is not in critical limb ischemia, he is in intermediate claudication or asymptomatic but has peripheral vascular disease. So at that point, you can say till 2B of Fontaine classification. 2B, the patient is not having rest pain more than 2 weeks or ulcer or gangrene. Like that, if there are no signs of critical ischemia, you can plan for pharmacotherapy. Okay, so what pharmacotherapy will give? So there are two drugs which are usually given. Okay, so the two drugs are, number one is silestazole and number two is pentoxiflin. First we will talk about pentoxiflin. So this was widely used before, when I was in my PG, and patients with peripheral vascular disease, not PG, sorry, internship. So they used to give this pentoxiflin to those patients, vascular disease, 400 mg orally 3 times daily they used to give. But now it is outdated drug. Okay, so because limited clinical benefit is noticed compared to the silestazole, and there is no evidence convincing the use of this pentoxiflin. Okay, what it is a non-selective phosphodiesterase inhibitor. But instead, what we are using now is silestazole. So what is the dosage? 100 mg orally twice daily. So it is a phosphodiesterase 3 inhibitor. So remember, we have discussed in our class of pulmonary hypertension. So there you have, that is phosphodiesterase 5 inhibitor actually. So this is phosphodiesterase 3 inhibitor. Difference is there. So phosphodiesterase, this is a 5 inhibitor, was pulmonary hypertension. This is in pulmonary hypertension. Okay. Second is phosphodiesterase 3 inhibitor. Okay, this is in peripheral arterial disease you use. Okay, here cyclic GTP is converted to cyclic GMP. So breakdown of cyclic GMP is inhibited here. Here what happens is, the thing which happens is here it is not the GMP. Okay, here it is the AMP. Breakdown of AMP is inhibited, cyclic AMP. So AMP is responsible for the dilatation of the, sorry, this AMP is it acts as an antiplatelet. It has an antiplatelet. It prevents platelet aggregation. It prevents platelet aggregation. It inhibits platelet aggregation. Platelet aggregation. Aggregation, one thing. One positive thing is it will vasodilate. So those two things we are getting from here by inhibiting the breakdown of the cyclic AMP by phosphodiesterase 3 inhibitors. One is we are inhibiting the platelet aggregation so that there is no propagation of thrombus, or you can say atherosclerotic plaque, and there is vasodilation, so that will increase the blood supply to the limb. So that's why silestazole is widely used now in patients with who are not considered as so much severe that they should undergo revascularization therapy. So in them you give silestazole. Okay, or some patients who are inoperable, there you can use silestazole. Okay, so that you should remember. Exercise therapy. So this is a kind of physiotherapy, supervised walking program. So how they should walk? 30 to 45 minutes 3 times a week for more than or equal to 3 weeks, means at least 3 months. At least 3 months supervised walking program, 30 to 45 minutes in one day and 3 times a week for at least 12 weeks. Okay, how they should walk to the point of claudication, then rest, and then again repeat. So this is how they walk. can be as effective as revascularization for functional improvement. So this is very important. Okay, so exercise therapy is also very very important. It can be as effective as revascularization for functional improvement. Okay, so remember we are talking about chronic uh, limb ischemia. Okay, not acute. So revascularization therapy chronic. So when it is indicated, so this is indicated when there is disabling claudication refractory to the medical therapy. Number one. Number two is when the patient is experiencing critical limb ischemia. So what are the options? So options can be divided into three. One is endovascular, second is surgical, third is amputation. Okay. Endovascular, what you will do? You will do something you do in a coronary artery disease, that is angioplasty. Okay, percutaneous angioplasty with or without stenting. So for stenting, you can use drug-coated balloons or stents to reduce restenosis. This is preferred for TASC A or B lesions, shorter proximal stenosis like iliac arteries. So when there is preferred shorter proximal stenosis like iliac arteries, there you will do this endovascular procedure. Okay, proximal stenosis of the shorter arteries like iliac arteries. Okay, and surgical. So similarly, like coronary bypass, you will have some peripheral bypass. So bypass surgery. So a vein, for example, saphenous vein will be taken, superior saphenous vein, autologous vein. This is considered superior to the prosthetic vein, tubes which are used for bypass. So example, what you do in this bypass, for example, if this is the artery and here is the obstruction. So what you will do, you will connect a vein from here to here. So what will happen? The blood, instead of flowing from here, it will bypass like this, and the limb will be perfused. Okay. Example for such procedures like femoropopliteal obstruction. So this is nothing but calf claudication, and this we have discussed now. Endovascular is for buttock claudication. So this becomes easier if we talk like this. Okay. So buttock claudication, endovascular, calf claudication, you can use bypass, femoropopliteal, and femorodistal bypass. So you can think this as uh, foot claudication. Okay. And one thing is in surgery, one is bypass, one is bypass is considered one endarterectomy is not possible. So endarterectomy is nothing but you remove the clot from the artery, that is endarterectomy. Okay. So plaque removal, commonly in common femoral artery it is done. Amputation is last resort for extensive necrosis or infection when limb salvage is not possible. Okay. Protection of the limb is not possible. These are the procedures: endovascular procedures, surgical procedures, and surgical bypass, and endarterectomy, then amputation. These are the four things which you do. Now, this is a management chart for patient with critical limb ischemia. Okay, what you will do? You will give some drugs for pain relief. Then you give stat intravenous heparin 5,000 international units, or else you can also give 40 mg to 60 mg of enoxaparin subcutaneously, or if you're giving IV, then 40 mg IV stat of enoxaparin also you can give. But one thing is, you can't use this enoxaparin in patient with kidney patients. Okay, because it has a long half-life and it is excreted through kidney. But you can give a low molecular weight heparin in kidney patients also, and this is cheap, this is somewhat costly. So depending upon the patient, you decide. So you will give stat treatment for pain relief for patients with critical limb ischemia, and then what you will do? Assessment of the patient prognosis and limb salvage with vascular surgical consultation. So I said no, whenever there is critical limb ischemia or when there is acute limb ischemia, first you will decide, you will classify the limb into three things. One is whether the limb is viable, number one. Number two, whether it is threatened. Number three is whether it is irreversible damage. So irreversible, if it is there, so the clue signs for irreversibles are fixed skin staining and tense muscles, meaning the rigor is set up in that muscles. Rigor. Okay. So in that case, you amputate the limb to save the patient. Otherwise, the infection will spread whole the body. Then severe is even threatened one. Okay. White leg, you will see white leg. So you will do surgery in, for example, in less than 24 hours. You will plan for surgery. Moderate is nothing but viable. Okay, dusky leg and mild sensory loss. Okay, sorry, I said this wrong. Severe is nothing but you plan surgery within 6 hours. Moderate is nothing but threatened. Viable. This is nothing but viable. So here you will take duplex or CT arteriogram to evaluate treatment modality. Meaning you are taking some time. Okay, so but surgery should be done ideally within 24 hours here, or it can be done in within days. You can take within days. It should be done. Elective. So this is elective. So decision, I will just say. So for a primary care physician who says the patient with critical limb ischemia or acute limb ischemia, he should do this one and he should refer the patient. So in viable thing, the decision is not elective. I can say it is urgent. Okay, here it is emergency. Here it is amputation. That's all. Okay, that is about critical limb ischemia. That's about the management. Now coming to the management of acute limb ischemia. Okay. So acute limb ischemia definition is already said. So what is the principle? Time is equal to tissue. So early you do the intervention, the limb will be more of the limb will be saved. Rapid diagnosis and intervention are important to prevent limb loss. Immediate anticoagulation. So what you'll do? You'll go IV unfractionated heparin 5,000 to 10,000 IV bolus, followed by continuous infusion. Or if continuous infusion is not possible, you give in BD dose. BD dose you can give 5,000 international units. This prevents thrombus propagation. Adjust infusion based on APTT. Okay, partial thromboplastin time. Okay, activated partial thromboplastin time. Okay, so you should monitor according to APTT. I said no. After giving this, in same is the case for critical limb ischemia. You should assess the viability of the limb, whether the limb is viable or it is threatened or it is serious. The decision depends upon that. If it is viable, urgent, meaning within 6 to 24 hours, you should revascularize the limb. Threatened, emergent revascularization, meaning within less than 6 hours, you should revascularize the patient. Irreversible is nothing but you are seeing rigor in the foot and fixed staining, and there is anesthesia, there is no sensation in the limb, and the limb is paralyzed. So in this situation, when you see these features, so this requires amputation. If you do revascularization, that is means there is no meaning of doing revascularization in this patient, and there is risk of reperfusion injury if you do revascularization. So when there is reperfusion injury, the products of that injury will be entering into the systemic circulation that will cause damage to the organs in systemic circulation. So that's how you will do. Okay. So what are the intervention options? So same options which we have discussed in chronic limb ischemia. One separate option is this one, thrombolysis. So how you do catheter directed thrombolysis? You will use a tissue plasminogen activator like streptokinase, or you can use alteplase, tinecteplase, all those things. So this is best for recent thrombosis, less than 14 days, meaning less than 2 weeks. This requires monitoring because it has complications of bleeding. Surgical embolectomy. So this is something similar like endarterectomy. There you remove the plaque. Here you remove the embolus, which comes from the atrial fibrillation. Bypass surgery similarly. Okay, bypass surgery as discussed. So this is indicated if native vessel is chronically diseased or unsuitable for embolectomy. Okay. Amputation is the last resort for non-viable with extensive necrosis and infection, prevents systemic complications. Okay. So how you will decide whether it is a viable limb or whether it is a threatened limb or it is an irreversible limb? So that is a very important thing. Okay, you have diagnosed that it is a critical limb ischemia or acute limb ischemia. Now the next step is whether it is viable, whether it is threatened, or whether it is irreversible damage. So that you should know. So to say it as viable, which does not not immediately threatened. So you see two things. One is sensory loss and one is motor loss. Okay, sensory deficit and motor deficit. No sensory deficit, patient is having the sensations. No motor deficit, patient has movements, proper movements. So what can be the treatment? It is something the intervention should be it can be an elective intervention limb is salvageable. Elective intervention, you will do duplex, you will do CT arteriography, and you will plan according to that. So as a general thing, you can do thrombolysis, meaning endovascular thrombolysis or surgery. Now, when you will say it as threatened, okay. Now, threatened can be divided into, this is from McMaster textbook of medicine, remember, and this is McMaster always gives updated things, okay. That's why I use this for treatment more. So 2A and 2B threatened things. So 2A is nothing but there is minimal loss of sensations. For example, say if you touch the toes, there are no sensations, but if you touch the other part of the foot, they have sensations, but there is no motor loss. Okay, so this is salvageable if promptly treated. So again, treatment is by thrombolysis or surgery. So you can say this as you should treat the patient within 24 hours. Okay, 24 hours. Okay, 24 hours. Okay. 2B is immediate treatment you require. Salvageable if promptly revascularized. Okay, now the sensations are not there more than the toes, not just toes, more than toes, and you have some motor loss also, mild to moderate motor loss also you are having. Then you should do surgery. Revascularization therapy is necessary. Here you have option, either you can do thrombolysis or surgery, but here you don't have the option. You must do surgery, and that can be combined with thrombolysis. The limb is salvageable. Threatened is nothing but the limb is salvageable. Okay. Irreversible, when you say profound anesthetic, no sensations in the foot, profound paralysis, rigor in the foot is set in. So paralysis with what do you call anesthesia. So that is irreversible damage. Inevitable high level amputation and permanent nerve damage is there here. So what you will do? Primary amputation in the cases of prolonged ischemia time with low likelihood of improvement and high risk of revascularization. So early 6 to 8 hour embolectomy or thrombectomy may be considered to determine the extent of reversibility or to improve the level of amputation. This is important point which this McMaster gives. So even in these patients, what you can do is you can try this one. You do first early embolectomy or thrombectomy, meaning you cut out the vessel and you take out the thrombus or embolus, and you see the limb. If there is some, okay, that is definite that total limb is not salvageable, but you can save some part of the limb by this. If some part of the limb is saved, then the extent of amputation will be reduced by this procedure. So this is an important concept you can remember in this irreversible damage. Also, you can do embolectomy and thrombectomy if possible and reassess the limb so that you can save some part of limb up. Okay, and then you will do amputation. Amputation is definitely done, but you can try this one first. Okay, so this is how you classify the limb with critical limb ischemia or acute limb ischemia as viable, threatened, or threatened again too, depending upon sensory and motor loss. Then you will plan the therapy according to that. Okay, this is a table from pocket medicine. Okay, so the pocket medicine, so the difference in that McMaster and pocket is nothing but the threatened part is considered 1 here. There the threatened part was like 2A, 2B. Here it is not 2A, 2B. Here just 1, 2. That's all. Okay. Same thing. Again, you will assess motor function, sensory loss. One thing is important here is capillary refill time is also taken in consideration here. So here the capillary refill time, if it is okay, then it is then it is considered as okay. Mean it is viable. If it is slow, more than 3 seconds, then it is threatened. If it is absent, then it is irreversible. Okay, that is the difference you should remember. So capillary refill time you can take along with motor function and sensory loss. Okay, that's about the management of acute limb ischemia, critical limb ischemia, chronic intermediate claudication we have discussed. Okay, now we will discuss some specific other related conditions of peripheral artery disease. So the number one is fast we will discuss. Okay, abdominal aortic aneurysm. Okay, definition: aortic diameter more than 3 centimeter. How do you screen? By ultrasound. In whom you will screen? Men more than 65 years of age and who are smokers. How you will manage? If the size of the aneurysm is less than 5.5 centimeter, you will do surveillance by ultrasonography. But if the size is more than 5.5 centimeter, then you will do repair. Or if the size is more than 5 centimeter, or if the aneurysm is symptomatic or ruptured, then you will plan for repair of the aneurysm. When it is ruptured, so the symptoms will be classical triad of hypotension, pulsatile mass in the abdomen. If you auscultate, okay, palpate, there will be pulsatile mass and back pain will be there. So this carries, the rupture of the aneurysm carries high mortality because there will be bleeding, lot of bleeding from the aneurysm. Okay, this is same from Oxford textbook of medicine. So when you have aneurysm, this is mainly in elderly patients more than 65 years of age, chronic smoker. Okay, and they will have back pain, dull aching type of back pain. So patients, usually these elderly patients, they have back pain due to nerve root compression, or some spinal cord, some rib fractures, sorry, not rib fracture, vertebral fractures. But you should also consider this one, aneurysm also one thing. So elderly patients, so they will have dull aching type of pain, but if you palpate the abdomen, you will have pulsatile mass there. Okay, so that thing you should remember, that aneurysm, abdominal aortic aneurysm. So less than 5 centimeter, as I said. So if the size is 3 to 4 centimeter, ultrasound surveillance is required, 1 to 2 yearly intervals. Every year you should uh, uh, do the ultrasonography. Intervention: stop smoking, control the hypertension, check the lipids. Okay, meaning you should control BP, lipids. If sugar is also there, that you should control, and smoking should be stopped. If it is 4 to 5 centimeter, and one every year you should do sonography. Here, if it is 4 to 5.5 centimeter, 4 to 5.5 centimeter, you will do it 6 monthly now, and you will do cardiovascular risk reduction here. So you will do statin, smoking cessation. So hypertension again you will control, sugar you will control. One thing is, you will add aspirin here. This is one important point for 4 to 5.5 centimeter. If it is more than 5.5 centimeter, or if the aneurysm is ruptured, or it is symptomatic, then consider intervention. Till then, you should have again same cardiovascularization, statin, smoking cessation, and aspirin. This is the management of men with asymptomatic unruptured abdominal aortic aneurysm stratified by aneurysm diameter. Okay, so that's how you manage abdominal aortic aneurysm, which is also a part of peripheral vascular disease. So similarly, in young patients, you see one thing, that is nothing but Buerger's disease, thromboangiitis obliterans. As the name is, there is a formation of thrombus. Angiitis is nothing but inflammation of the blood vessels. Obliterans is obstruction. Inflammation, thrombus formation. So due to inflammation, there is thrombus formation. Because of thrombus formation, there is obstruction. Why inflammation? Inflammation is by the nicotine which is present in the smoke. Okay, so that is thromboangiitis obliterans. So this is seen in young patients less than 45 years of age, and they are male smokers. Pathology: there is inflammatory thrombosis of small and medium vessels. So that means the ischemia is present in distal side. It involves fingers and toes. So upper limb fingers, lower limb toes it involves. So this should be differentiated from peripheral arterial disease of diabetes and type 2 diabetes and CKD patients, because they will also have this kind of peripheral artery disease, this kind of presentation. But there the patient will be somewhat, they are not young. Okay, they are not young, they'll be aged more than 50 years, 55 years, like that. What will the clinical presentation? Same, claudication of arch of foot or hand. See, they are involving the foot and palm, arch of foot and hand. And they can also have superficial thrombophlebitis, meaning inflammation of the superficial veins. And they can even have Raynaud's phenomena. Raynaud's phenomena in male always suspect first Buerger's disease. In female always suspect first connective tissue disorder. Okay, you can, connective disorder can also present in male also, but first you need to suspect this Buerger's disease in male, and there you can suspect SLE or scleroderma or something like that in females. So what is the treatment? No treatment is there except to quitting smoking. Complete smoking abstinence is the only effective treatment to prevent amputation. So this occurs not in all patients, but there is some genetic predisposition in this. Okay, that's why these young patients who smoke, they will develop this kind of thing. So distally, the foot and the palms are involved, toes and fingers are involved. Raynaud's phenomenon can be there in these patients, young, less than 45 years of age. Raynauds phenomena. Come to particular Raynauds phenomena. Okay. So what is this? This is episodic digital ischemia. So first you will have paler, white fingers, then that will change to cyanosis, blue fingers, then they will change to red fingers. That is nothing but rubor. So that is the sequence of events which happen in Raynauds phenomena. And sometimes there will be, uh, uh, if severe, they will have ulcers at the tip of the fingers or toes. At the tip of the fingers or toes. This is due to cold and stress. Okay, cold and stress. That can be due to primary Raynaud's disease and secondary Raynaud's syndrome. Primary is you don't have any disease, it is idiopathic in nature, symmetrically present, and young woman it affects. And there is no tissue loss, meaning there is no ulcer, no amputation. Okay. Secondary Raynaud's syndrome, this is associated with some connective tissue disorder like scleroderma, SLE, or trauma. So there is more risk of ulcers and gangrene in this. So remember, this secondary Raynaud's syndrome, they are prone for ulcers and gangrene, but primary Raynaud's syndrome, they are not prone for ulcers and gangrene. That is the differentiation between primary and secondary Raynaud's phenomena. And this is, I said now, in Raynaud's phenomena, if it is in males, first you suspect Buerger's. In females, first you suspect some connective tissue disorder, or it can be idiopathic also. What is the treatment? Keep the extremities warm, and calcium channel blockers like nifedipine are usually used in the what do you call, sustained release form. Tablet form you should use 20 to 30 mg. 20 to 30 mg. BD or OD, BD usually is used. You should monitor the BP of the patient because it can fall in these patients. Okay, that's about Raynaud's phenomena. Okay, Raynaud's phenomena usually in young females. If it is occurring in males, first you should bear in mind about Buerger's disease, then connective tissue disorders. This is something called as blow-to syndrome. This is because of atheroembolism. Cause is microemboli. This is given in Harrison, so need to discuss. Cholesterol crystals from proximal plaque. So they come and they will block the distal small arteries. So what will happen? Pale, full cyanotic toes with palpable pedal. See, the main here thing, the pulses should not be palpable if there is peripheral artery, but pedal pulses are palpable. Pedal pulses are palpable, but the toes are cyanotic. See here, this is a picture. Cyanotic bluish discoloration of the toes. But if you palpate the pedal pulses, for example, dorsalis pedis, it will be palpable. So at that time, when the dorsalis pedis is palpable and the toes are bluish, having bluish discoloration, so if it is a male, then you can suspect their Buerger's disease. Okay, or if it is a female, you can suspect their Raynaud's phenomena. Raynaud's phenomena. Okay. Or otherwise, it can, if it is not there, no Raynauds, no Buerger's, then it can be a blue toe syndrome like thing. Okay. One thing you should remember, you should always differentiate. This is vascular claudication. No, vascular claudication. You should differentiate it from neurogenic claudication versus vascular claudication versus arthritis pain. Remember, in neurogenic claudication, there are two things. One is spinal stenosis, lumbar canal stenosis in elderly individuals. So they will have same, what they will have, when they walk, they will have pain in the bilateral buttocks. Okay. And the pain is relieved by leaning forward. This is a differentiating point. Lumbar flexion, not just rest. How do you differentiate? Peripheral pulses are present. Posture dependent relief will be there. And this position is now, this position of these patients, they have a typical position. What do you call that? Gorilla like walking posture they will have. Okay. Something called as something it is called. Okay. So when they walk upstairs, because they bend during walking upstairs, they will not feel pain. But when they walk downstairs, then they will be straight. So at that time, they will experience pain. So that is typical feature of spinal, meaning neurogenic claudication due to LCS. But pulses will be palpable. But remember, because they are elderly individuals, they can even have this vascular claudication. You should see. Okay. So second is venous claudication. So all this claudication which we have discussed, that is arterial claudication. Okay. You should differentiate from venous claudication. So you will have bursting type of pain due to, so for example, deep venous thrombosis or varicose veins. Bursting pain often after exertion. Okay. But one thing is, they will have relief with leg elevation, and there will be history of deep venous thrombosis in these patients. Or they will have varicosity. Superficial veins will be varicosity. Varicosity will be present when you examine the patient. Okay, that will give a clue. So neurogenic claudication, one is LCS, next is neuropathy. So you'll have burning, numbness, tingling sensation in bilateral foot or the palms. Symptoms are present even at rest. Okay, not strictly exercise related. That's how you can differentiate. Arthritis is pain which is just linked to the joint movement. Pain depends on joint use, not walking distance. Okay. So vascular claudication you have discussed. Bursting type of pain they will have, not claudication type of pain, they will have bursting type of pain. So you should differentiate it from spinal stenosis, venous claudication, neuropathy, arthritis. Okay. So this is the summary of whole topic of peripheral arterial disease. Okay. Onset, this is intermediate claudication, meaning chronic, and this is critical limb ischemia, CLI, and this is acute limb ischemia. Onset is chronic, predictable. This is chronic, progressive, and it is sudden and emergent. Pain pattern, this is precipitated exercise relieved by rest within 1 to 5 minutes. This is constant rest pain, worse at night or when supine position, relieved by dependency. So this is sudden, severe pain, distal, and it has proximal progression. First, it will be at the distal side, then it will progress to the proximity. Okay. Physical sign, there will be reduced pulses. You can have bruit and hair loss, skin atrophy. Here you will have Buerger's sign positive. This is also one important point. So to say it as critical limb ischemia, Buerger's sign will be positive. Patient will have non-healing ulcers, gangrene. Here you will should remember 6 P's. Pain, pallor, okay. Poikilothermia, pulselessness, paralysis and paresthesia. Ankle brachial index will be 0.5 to 0.9. Here it is less than 0.5 in critical limb ischemia. Here it is often unoptimal because it is an emergency situation. Okay. Urgency, it is elective management. Here urgent management within days, and ideally the book says within 24 hours in critical limb ischemia. And is emergency management within hours. Golden window is less than 6 hours. First line treatment, smoking cessation, statins, aspirin, supervised exercise therapy in these intermittent claudication patients. Okay. Here in critical limb ischemia, you will have medical therapy. Okay. You can give medical therapy here as well. Medical therapy along with revascularization. Medical therapy is in the sense you will give heparin, okay, anticoagulant. Revascularization by bypass, angioplasty, and vascular options. Here you will give IV heparin immediately, plus embolectomy, catheter-directed thrombolysis. Primary goal here is to improve the walking distance and reduce the cardiovascular risk. That is one. Here it is to for the limb salvage. So in both, you remember, in these two, if you get, you will decide viable, threatened, or irreversible. Then you will plan the treatment accordingly. Okay. Now I will summarize the approach to how to manage these patients. Okay. So I will summarize the approach now. So you will say a patient coming with claudication pain with claudication. Rule out red flags. What are the red flags? Whether there is gangrene in this patient or non-healing ulcers. Non-healing ulcer or gangrene, if rule out this, or rest pain. Rest pain for more than 2 weeks, that should have a history of plus history of chronic claudication. So these are the red flags. Okay. Rule out this. Once these are ruled out, that means the limb is not in critical limb ischemia or not in acute limb ischemia. Now you will differentiate from neurogenic claudication, vascular claudication, and next is from joint pain, arthritis. Joint pain you should differentiate. Arthritis. In neurogenic you will have two things. One is lumbar granule stenosis and the other one is neuropathy. You should differentiate. So once you have differentiated, vascular in the sense artery from venous, bursting type of pain. You will have no offer extension and it relieves by raising the limb. Okay. Whereas in intermittent claudication, if you raise the limb, it will aggravate. Okay. So once you have differentiated this one, okay, and you have confirmed that it is arterial, chronic peripheral arterial disease, then again you will see. Now you will whether it is viable or threatened or irreversible. Again you will see these things. Okay. Now if it is viable, then you will modify the risk factors and you can use silastazole in this patient. Silastazole. Threatened, so you will plan according to thrombolysis or surgery. So 2A and 2AB, no, 2A is thrombolysis surgery and 2B surgery along with catheter by catheter induced thrombolysis will do. Irreversible, you can do embolectomy and thrombectomy so that the limb is the amputation extent will be decreased. The extent of amputation can be decreased. So this is the whole framework of claudication. So what you will do, approach, if you suspect claudication, rule out the red flags of intermittent claudication, critical limb ischemia and acute limb ischemia. That is nothing but gangrene, non-healing ulcer, rest pain, 2 weeks. One more thing is 6 P's you rule out. Of If not there, then you will differentiate whether it is neurogenic, vascular meaning venous, or arterial, or it is a joint pain. It is not neurogenic, it is not joint pain. Now again you will classify whether it is viable, threatened, or irreversible. Viable, you will give medical therapy. Threatened, you will plan. Irreversible, you will amputate. That's all. Thank you.